Greetings. Let us learn about how to measure portal hypertension. These are my acknowledgements, and please take time to review the notice. So, before we learn about how to measure portal pressure, we need to review that the portal vein is formed by the confluence of splenic vein and superior mesenteric vein, and it goes into the liver and branches into right and left branches of portal vein. And then it divides further and further till it reaches the portal triads of the lobule. And then through the sinusoids, it drains into the central vein. And then from there, central veins join to form the tributaries of hepatic veins, and then ultimately hepatic veins and IVC. So portal pressure could be measured by several different ways. And as you can see here, you can do direct pressure measurement. And this is what people used to do long time back. When portal hypertension in the 50s and 60s and even up to 70s was predominantly managed by surgeons. And at that time, endoscopy was not well developed. So when surgeon went in, he measured directly from the portal vein by hooking up to a catheter and measuring the pressure. And when I was training in the 1980s, we used to puncture the spleen of patients with portal hypertension and do transsplenic pressure measurements. In the 80s, at that time during my training, we didn't have ultrasound, and we felt the spleen, and under fluoroscopy, we punctured the spleen with a needle and attached a pressure gauge. When ultrasound became available, the radiologists were able to access the portal vein through the liver, the transhepatic route, for measuring portal pressure, another option. In the last few years, in the late 2015, 2020 time, a group of investigators from California looked at how to puncture the portal vein branch supplying the left lobe of the liver that is easily accessible using an endoscopic ultrasound that is passed down the esophagus into the upper portion of the stomach, and under ultrasound guidance, a needle was punctured and the transgastric portal pressure measurement could be taken. So these are all different ways of direct portal pressure measurements. And all of them have risks, so we need to look at if there is an indirect way of measuring the portal pressure without puncturing the portal vein. So for this, we send the patient to a radiologist, interventional radiologist, and he passes a catheter from the right jugular vein down the superior vena cava, right atrium, down the inferior vena cava, and then place the catheter in the hepatic vein. And with the catheter there, this is a catheter with a balloon, and with the catheter free floating, you measure the pressure, that is free hepatic venous pressure. And you take about 3 readings, and after that, you inflate the balloon at the end of the catheter, that is almost wedging the catheter into the hepatic vein. and again measuring the pressure, that is wedge hepatic venous pressure. So if you have done ICU rotation, in the ICU people do pulmonary capillary wedge pressure. It's a similar concept. When you wedge the catheter and inflate the balloon, you're creating a closed circuit and you measure the pressures that are transmitted from the central vein and along the sinusoids. So wedge hepatic pressure reflects sinusoidal pressure. That is something important to keep in mind. And the difference between the wedge hepatic pressure and the free hepatic pressure is known as hepatic vein pressure gradient. Normally, that is less than 5 millimeters of mercury. So when you do the wedge hepatic pressure and you also measure the free hepatic pressure and the hepatic vein pressure gradient is less than 5 millimeters of mercury, you know that the patient has no portal hypertension. That is making sure that the portal vein is patent and there is no other disease affecting the portal triad. That is a caveat you have to keep in mind. And when you measure the pressure and the pressure is above 5 millimeters of mercury, you diagnose the patient as having portal hypertension. So in another patient, if the pressure comes as above 10 millimeters of mercury, then you diagnose the patient as having clinically significant portal hypertension. So patients who have clinically significant portal hypertension, the hepatic vein pressure gradient is 12, 13, 14. That means that patient with cirrhosis, with clinically significant portal hypertension, is at risk for decompensation. So this is a very important point. You have patients with cirrhosis with compensated state and decompensated state. When they have decompensation, you know that the patient either gives a history of bleeding or ascites or encephalopathy. If you don't have any of those features and you feel that, hey, this patient doesn't have decompensation, and you think that the patient is compensated cirrhosis, but if the hepatic vein pressure gradient is more than 10, that is indicative of a clinically significant portal hypertension, you should worry that this patient is likely to develop decompensation. On the other hand, if the pressure is above 20 millimeters of mercury, that is indicative of severe portal hypertension. Patients with severe portal hypertension are at high risk of complications, major risk for big bleeds that may not be controlled with whatever we do, and higher risk for mortality. So we talked about measuring portal pressure by direct means, indirect means by calculating the wedge hepatic venous pressure, free hepatic venous pressure, coming up with hepatic vein pressure gradient. If the gradient is above 5 millimeters of mercury, portal hypertension. About 10 millimeters of mercury, clinically significant portal hypertension, at risk for decompensation. About 20 millimeters of mercury, severe portal hypertension. So when you see that, you should be worried about how the patient is going to do. And I want to thank authors of this beautiful guideline statement that came out recently. And this helped me create this material. And I hope this is helpful to you. Thank you.